Prognosis for patients with oncogenic drivers, for the most part, are better than patients who have wild-type tumors. A patient with an ALK rearrangement on crizotinib or one of the newer agents, ceritinib or alectinib, can expect to have a progression-free interval minimum of 8 to 10 months frontline. The newer agents that can approach 2 years or more. And their overall survival, median survival, is in the range of 3-4 years, and there are clearly some patients who are alive now a decade after diagnosis, and this is despite having metastatic cancer. So in general, the prognosis, certainly the median survival, is 2 to 3-fold higher than we typically observe in a wild-type non-small cell lung cancer, an individual who does not have an oncogenic driver. Up until 2016, crizotinib was the standard approach in this sort of patient. In fact, it was the only approach. We had credible, prospective randomized phase 3 trials that showed a clear-cut response and PFS advantage compared to standard platinum doublet chemotherapy in this setting. More recently, ceritinib has shown a similar, even more profound advantage compared to standard chemotherapy, with median progression-free survival not 10 or 11 months, but 16 months or higher. And last year, 2016 at ASCO, and now this year at ASCO 2017, we've seen 2 separate trials showing a profound advantage for alectinib, another second or third generation TKI targeting ALK, compared to crizotinib. So I think that those studies will ultimately lead to a formal approval for alectinib in this setting. Currently, it is not yet FDA approved, at least as of mid-July 2017, but I'm speculating here. I suspect in the next month, 2 months, 3 months, that approval will be forthcoming. And the data are really quite impressive. In the J-ALEX trial, which compared alectinib to crizotinib in treatment-naive ALK-positive non-small cell, the median progression-free survival for alectinib had not even been reached. The lower end of the confidence intervals was more than 20 months, compared to a fairly standard 10 months or so for crizotinib. Response rates were at least as good. Intracranial response and progression-free survival was clearly superior for alectinib, and toxicity was less. So on every endpoint, every objective of that trial, alectinib was superior to crizotinib. And this year at ASCO in June of 2017, we saw a similar trial, global ALEX, essentially the same design, although the dose of alectinib was higher. It was 600 milligrams twice daily instead of the Japanese dose of 300 BID. Essentially the same outcome measures. Median progression-free survival, that was at least 25 months compared to 10 months for crizotinib. Response rates, again, edging out crizotinib, although I don't believe the differences were statistically significant there. Again, we were starting off with a response rate of over 70% and inching up to 80%. Far less toxicity, significantly less toxicity overall. And intracranial progression-free survival, that was far superior. The chance of having brain metastases in the control arm was about 40% or so for crizotinib. It dropped to less than 10% for alectinib. So the new generation TKIs, and this doesn't apply just to alectinib, it applies to ceritinib and to brigatinib and to other agents, actually has a protective effect on the CNS. And at the end of the day, CNS progression, unfortunately, is often the terminal events that occur in these patients. We will often observe excellent extracranial control, but the CNS is the site where the disease ultimately progresses and can spell the patient's demise.